So I started doing moderate sedation back, oh my gosh, 25 plus years ago. Back in the day, we had one nurse in the room and one doctor in the room. I actually started all my IVs, and I actually pushed all my own medications. Yeah, so, to now, and we only used a pulse ox, and, we measured vital signs before and after, but we didn't even put oxygen on patients unless they got hypoxic, because it really was truly, a moderate level of sedation. So, one of the things for us to think about to begin with is that preparing our patients properly for the type of sedation that they're going to get. One of the mistakes I see, even with, the anesthesia monitor deeper sedation, is that we promise the patients that they're going to be asleep. We should never promise a patient that they're going to be asleep. We should promise that we're going to keep them comfortable and that we're going to keep them safe. But setting up those expectations ahead of time, so you may wake up during, the procedure. That's not abnormal. Because I'm sure you guys have heard the patients say, I woke up in my last procedure. It's like, hey, sounds like they were doing things, safely. Were you uncomfortable with that? Tell me about, what your experience was, so that then you can kind of help relieve, the anxiousness or concerns that they may have. So moderate sedation, just for those of you who are old and gray-haired like me, was previously called conscious sedation. The current terminology, though, is now moderate sedation. The reason we call it conscious sedation in the past is that we expected our patients to actually be looking at us. They weren't necessarily, closing their eyes at all. I remember using like one or two of Versed is all I would use for upper endoscopies, and I would talk the patient through the procedure. And that's one of the things that both the doctors and the nurses will have to get used to, is like, how do you talk your patient through the sedation as you're giving it. A key point about moderate sedation is that ventilatory and cardiac function are preserved. And that's different in deeper sedation. I'll compare and contrast in two slides. The other thing is that the patient is able to make purposeful movement. They may kind of, drift off a little bit, but as soon as you verbally stimulate them or just kind of touch them, say, hey, I need you to roll on your back. They're actually able to help you roll on their back. Suppose now we got to roll a patient on the back. It's like it's a three-person lift, to try to get that to happen. Whereas with moderate sedation, the patient should be able to help you. So there are basically 4 levels of sedation that, from an anesthesia perspective, that we talk about. So one is minimal sedation, and this is not, we can use this, but this is not something typically that we use. The patient's able to talk to you pretty much completely normally. Their coordination may be off, they may be a little bit goofy, but they can pretty much do whatever you ask them to do. Moderate sedation is what we are talking about. So it's a drug-induced depression and consciousness, but the response is appropriate to verbal stimuli alone, or just with like, Ms. Jones, are you doing okay? Or Ms. Jones, how are you? Deep sedation, the patient does not respond easily. You got to really shake them to kind of, try to get them awake. But they do maintain ventilatory function, although it could be impaired. So you've got to be much more ready to rescue in patients that are under the deeper sedation. And then anesthesia, obviously, it's drug-induced loss of consciousness. We don't want our patients to be conscious. This is when we're intubating the patient, getting them prepared for surgery. Patients are not aroused, even with painful stimuli. Now, we're not providing the same type of anesthetic with the deep sedation, the intubation that we do in the advanced room for some procedures. So there is a difference between what we're doing in the advanced room versus what they're doing in the operating room. But the point is, the patient is not able to maintain their airway on their own with anesthesia induced sedation. So again, I kind of like, kind of a Disney fan. And so minimal sedation is kind of anxiolysis, like, don't worry, be happy, but I'm sitting here and I can have a conversation with you. Whereas moderate sedation, like, oh, I'm kind of sleepy here. But yet you can arouse them if you need to. Versus deep sedation, yeah, it takes a little bit more effort to kind of wake you up. So let's kind of compare and contrast. So I've got minimal, moderate's what we do in the middle, deep, and then general. And so if you look at the moderate, purposeful response to verbal or tactile stimulation. So you might hear me say, Ms. Jones, take a deep breath for me, or Ms. Jones, I need you to roll over a little bit. So there's, for airway, typically no intervention required. For spontaneous ventilation is typically adequate, and cardiovascular function is well maintained. Now, Minimal sedation, there really isn't any effect with that. They should be fine. The deep sedation, which is what we've been providing to this point for our patients, is that with airway, think about how often we do have to intervene with the airway right now. It's not uncommon that anesthesia is doing a chin lift, a jaw thrust, putting an airway in. That's actually not uncommon. Spontaneous ventilation may be inadequate, so you've certainly seen times when we've had to stop and bag our patients. That's not a complication of deep sedation. That's part of one of the responses you need to be able to deal with. And cardiovascular function is usually maintained, but you've also noticed that anesthesia sometimes has to give our patients a little bit of medication to support their blood pressure, not that uncommonly. And then general anesthesia, obviously all of those may be impaired. Even though I've put these in nice, neat little boxes, the reality is that sedation is a continuum. And so you can't always predict when patients are going to kind of transition from one phase to the next. I've had patients that I gave one a Versed to, and I had to support their airway. I've had a patient that I've given 12 milligrams of Versed to, and they're still, they're in that stage one. They're still looking at me, talking, and having a happy time like they just had a beer or two. So the key is that you need to be able to rescue your patient no matter which stage in the sedation continuum that they are. Obviously, we shouldn't be getting to the point of, a general anesthesia, and if we do it safely, that should happen rarely. In my entire career, I've had to give a reversal agent less than 10 times. And so, it is not an expectation that they're going to get so deep that you have to intervene with a reversal agent. And what I would like to see us do is that any time we have to give a reversal agent for conscious sedation, I want us to keep track of that, especially if we're getting started, and I want us to review it, because I want that to be an uncommon thing. And if we're giving reversal agents, every week, I need to, instruct me, my fellows, my, faculty about what's truly expected with conscious sedation. So credentialing. So these are our hospital's credentialing rules. The physicians must be credentialed to administer monitored sedation. That's in any physician's credentialing packet, except for anesthesia, because obviously that's part of what anesthesia does. So all of our attending should be credentialed to moderate sedation, but that is something that we do need to check to make sure that that is true. If there are any attendings that are not credentialed in moderate sedation, please let me know so I can help get them trained.
How do I check that out?
Medical staff office. But there actually should be on the website. Electress, do you know where you go to look for privileging on the website? Yeah, so the same place where you look and say, concerning Craig to do an ERCP, and you look and say, yeah, she's not credentialed to do an ERCP, I'm not going to do that. You can look up the moderate sedation, should be there as well. But just to make sure we're crossing our T's and dotting our I's, let's make sure that anybody that's going to be doing it is credentialed. For the nurses, you have to have an active license, kind of duh. There is an online learning module that I think Mitch chatted with you guys about that needs to be completed. It's not too long. It's relatively, straightforward. I haven't seen it, so hopefully this talk today will provide most of the info that you need to do well with that. But you do need to have current ACLS certification, and you guys had a little ACLS refresher, I think, just last week.
Yeah, we have a continual ACLS.
It's required.
Yeah, which
like
is
every 3 months.
fantastic. Now, to be perfectly honest, the number of times that you're going to have to manage cardiac arrhythmias is like incredibly rare on the patients that we're doing, on the patients that we should be picking for moderate sedation. However, the ability to manage an airway, absolutely critical to recognize early airway compromise and to intervene early to keep the patient from developing the cardiovascular complications, because they're going to develop respiratory depression, before they develop their blood pressure changes, their cardiac arrhythmias. So if you can identify and rescue early, your patients are going to do just fine. Now, believe it or not, fellows can be credentialed here at SLU to independently provide moderate sedation. I do make them go through the module, but it is my expectation that the fellows will be supervised by the appropriately credentialed attending. And so, and again, it kind of makes sense. We're doing the timeout anyway. If we go out the room, we come back in, we got to do another timeout. So, once you decide to do the procedure, you know, we should all, you know, be in there and ready to go. So I can't imagine a situation where the fellow would be providing moderate sedation independently without a faculty member there. So what are the SLU requirements for moderate sedation? Well, in general, it's a minimum of one physician and one nurse is the requirement. So the nurse administers the moderate sedation under the direction of the physician, monitors the patient, and must be able to recognize apnea and airway obstruction. They may assist with minor interruptible tasks. However, the sedation must continuously be monitored. So if you need to help reposition a patient, you know, that's certainly fine. If you need to grab something in the room quickly, that's certainly fine. Assist with polyps, you know, the bottles that we use, closing them, getting the labels, those sort of things. Those are all things that can be done with conscious sedation. However, you shouldn't be, you have to always be able to monitor what's going on with the patient when you are doing that. So it shouldn't, you know, your primary task remains monitoring of your patient. So what are the required equipment for SLU regulations? A hand mask bag, and again, it has to be immediately available, which means it doesn't have to be in the room, but it would be my preference that we have a bag with a mask in the room, and that be part of our timeout. I don't think so. Part of our timeout currently. It'd just be nice to know, because sometimes if you use it and if it hasn't been replaced, it's not something that you would necessarily notice. And not that we can't grab it from the crash cart. I mean, it is right there. But it's nice to be able to rescue within, you know, a second or two as opposed to, you know, half a minute.